All right. So we just finished by talking about um, the first study, which was looking at degree motor blockade, and it was a pilot study. So a few years later, we had some more nurse anesthesia students come through our program, and we wanted to follow on and really answer that question and build off the weaknesses that we had identified in our first study. And so uh, with this one, same design, we did a randomized controlled trial, and this one was a 46 parturients who got the same exact, it was essentially the same exact study. The difference being that we looked at time to full motor recovery and time to two dermatome regression. We also added in some additional controls within the study to adjust for to limit the to identify to adjust for the limitations found in the previous study. So it was a two-group randomized controlled trial. It excluded women who required top-up boluses other than the 1/8% bupivacaine with 2 mics per cc of fentanyl prior to enrollment. In our first study, we had not done that, and so we made sure that when they were enrolled, that's all they had received via their epidural. We also made sure that this time we blinded the patient, the nurse, and the data collector to the group assignment. We actually had a sham injection, and basically somebody that was not connected to the study would go in and administer the bolus. They would use a syringe, and we'd ask the nurse to step out of the room, and somebody would hook up a syringe and simulate like they were giving something to the patient. Now, you could say the patient probably still could figure things out, but it's the best we could do. So what was the independent variable? Same thing, it was a 30 cc saline bolus or not. The dependent variables are our outcomes, and this was based on the recommendation from the first study, was that we looked at time to complete motor block recovery in minutes and time to two dermatome regression, which is another outcome measure we had commonly seen published in the anesthesia literature. The level of measurement of these dependent variables, well, the nice thing is they're both continuous measures. So what type of statistical analysis do you think would be most appropriate? Well, independent t-tests, and we also did what's called a Kaplan-Meier survival analysis, that we looked at modeling the time to complete motor block recovery between the two groups. And we're not going to get into that in this discussion, but the following lecture will talk about survival analysis, and we'll go over some examples in there. And you can see the level of significance was less than 0.05. So same thing. How did the students go about calculating their effect size? Well, we ended up using a lot of the same literature from our first study. And we used this article by Johnson et al. That had found a fairly large effect size. And so we were actually going with an effect size of 0.86, looking at with an alpha error of 0.05 and a beta of 0.2. So we came up with needed 23 subjects per group, and that would allow us to find approximately a 50-minute difference between the two groups. Now you could make the argument is, well, you didn't really find that in the first study. Why, you didn't think you could find a large effect size. Well, it's one of those things where you kind of have to balance stuff. You have crucial questions you have to ask and decisions you have to make that you have to look at the strengths and weaknesses of those. So what was the magnitude of this effect size that we said that we were proposing we would find? 0.86. Same thing, I entered the data over here. And with an effect size of 0.86, is that small, medium, or large? Well, if we go back to our Cohen's d in the table, it's considered a large effect size. Now, this just helps you illustrate the differences between a smaller effect size and a large effect size. So here we said 0.86. So you can see here as the power, so if we go to power of 80%, you can see here we only needed about 46 women. However, if we went with a medium effect size, that goes up to almost 125 women. So you can see how this really helps illustrate the magnitude of that difference between those two groups in terms of the sample size you need to achieve a given level of power. So I was talking about just a few minutes ago. Why did we choose an effect size based on why did they not choose an effect size based on their previous study? Well, the previous study that was done looked at degree motor blockade, not time to complete motor block recovery. So we had to go back to the literature and we used the best available evidence that we had at the time. The other factors was that this was a student study. I mean, the students had a lot of other things to do, and they were juggling their clinical responsibilities, their academic responsibilities, their family responsibilities with trying to get this study done. And so we had to factor that into our decision making. And so we chose to go with a larger effect size. All right, so what did we find? So this is our table 1. You can look at our basic demographics. There was no significant differences between the groups on any of the demographic characteristics. Now, if you look at figure 1 in the manuscript, we found a mean difference of approximately 17 minutes between the two groups. Our sample size, we lost a few patients, but we did pretty good. We ended up with 40. Our estimate was 46, so we were one short in each group. Pretty darn good. So we found a difference of time to full motor recovery was 83 minutes versus 100 minutes in the control group. Pretty large standard deviations of about a little less than an hour in both groups. However, this difference was not statistically significant. The t-value was 1.1 with degree of freedom of 42 and 27. Here, I also show you their sensory dermatome levels. There was absolutely no difference between the groups on any of those. On any of the sensory dermatome levels. So in the discussion, what we talked about was our findings were not statistically significant, nor did we actually feel that they were clinically significant or clinically relevant. And one of the problems that they found was that using such dilute local anesthetics made it hard to detect a difference. Because we only had 4 participants with complete motor loss of function, whereas a majority of them had only partial or no loss of motor function. So when you're using such dilute local anesthetics, the magnitude of the effect size is probably you're going to need, it's much smaller than we had anticipated. And so we concluded the same thing, unfortunately, that our study may have been underpowered. And we went further. How did we justify that conclusion that the study was underpowered? So what we did was we actually went back and used our results, and we calculated an effect size. And our effect size ended up being 0.35, not 0.86. And so we actually only had a power of 0.31 or 31%. To achieve a power of 80%, we would have needed 100 subjects per group. So over here, I calculated the effect size. I did an effect size calculation in here, 0.35. You see it only shows a power of 30% using a one-tailed t-test here. And then when we go in and we input that in, doing a looking at the magnitude of the effect size. So then now if I want to go in and say, okay, what size of a sample size, how large of a sample size would I need in the future? So I inputted that effect size in G-Power. using the a priori, this setting with mean differences between the two groups, using the alpha error of 0.05, the beta of 0.8, a one-to-one allocation. And this is what it came up with. To achieve 80% power, we would need over 200 subjects per group. You can see here, this shows it right here on this example. And if we were to extend this back with this effect size, in effect, if we went way back then, we're at 30%, so we're way back down there at where we were. Okay. So in fact, that was actually probably a small to medium effect size that we actually found. So the conclusion was that, as I said, the study was underpowered and we may have committed a type 2 error again. We also felt that really a 17-minute difference was not necessarily clinically relevant, especially given it might be difficult to do on a busy OB practice, and so it may not be feasible. And so we concluded that it was, although it appears to be safe, it probably, even though we were underpowered, we would need such a large sample size that it really was not worth doing another study looking at this.